Hello, everyone, and welcome. My name is Jamil Williams. I'm an MS3, Rising MS4 at Howard University College of Medicine, and I'm the current Specialty Interest Group Liaison for Emergency Medicine. I want to welcome everybody to the start of the Sowing Seed Specialty Series. We're going to be starting this off with the best specialty of all time, emergency medicine. This series is a part of our Sowing Seeds program, which was created during the pandemic and continued by our National President, Chantel Thompson, in collaboration with the Alumni Affairs Committee. Throughout this year-long program, we will be providing resources on how to succeed as a pre-med and medical student, and we'll touch on everything from financial literacy to preparing for board exams and more. So make sure you're a national member by visiting snma.org and signing up to stay in the know. So without further ado, I'd like to welcome our great panelists. So to start off, Dr. Steve Pamphil. He's an emergency medicine resident. He's a PGY4 at Jacobi Montefiore residency program. So thank you, Dr. Pamphil.
Good to be here with everybody.
Next up, we have Dr. Tyson Pillow. He's an associate professor of emergency medicine, also a resident program director of emergency medicine, and the medical director of simulation and standardized patient program at Baylor College of Medicine. Thank you, Dr. Pillow.
Absolutely, glad to be here.
Next up, we have Dr. Lynn Holden. She's a professor of emergency medicine, and she's the vice chair of diversity, equity, and inclusion in emergency medicine at Albert Einstein College of Medicine. She's also the president of Mentoring in Medicine Incorporated.
Hello, everyone. Great to be here.
Thank you, Dr. Holden. Dr. Felipe Serrano. He's an assistant professor of emergency medicine, an associate resident program director at Mount Sinai Morningside West. Thank you for coming, Dr. Serrano.
Thanks, Jamil. Excited to be here.
And last but not least, Dr. Mohammed Muritala. He's an emergency medicine resident. He's a PGY3, also at Jacobi Montefiore residency program.
Hi, Jamil. Thank you, guys.
I want to thank all of our panelists for coming on and being with us today. We really appreciate you guys. Also, for anybody who's watching, please feel free to ask any questions. Go ahead and put them in the chat. We'll go ahead and display them on the screen as we go, and we'll have some time later to answer any questions that you guys have. So don't hold back. So to start off, we'd like to kind of get into the introduction of the panelist stories. So we'd like for our panelists to just answer a couple questions for us. Just kind of tell us about where you trained for medical school, where you currently are practicing now. How did you choose the field of emergency medicine? Did you have any mentors in the field? And maybe ending off with your favorite thing about the fields of emergency medicine. I know it's a lot of questions, so I can repeat them. Where you trained for medical school and where you are now. How did you choose emergency medicine? Did you have mentors in the field? And your favorite thing about emergency medicine? Anyone can start.
I can go, since I have a couple of mentors in this program. So as you said, I'm an assistant professor at Mount Sinai Morningside West. I went to medical school at Baylor, where Dr. Pillow, who's on this panel, was actually, I think you were one of the APDs back then. I don't remember, to be honest with you, but you might have been associate or assistant. It's hard to remember, even though it's only been like 8 years. I went to residency at Vanderbilt in Tennessee, and then I graduated in 2015. I worked at Montefiore, where Dr. Holden is an attending, for about 3 years, and then I made the move to Mount Sinai Morningside West, formerly known as St. Luke's Roosevelt. We changed our name about 5 years ago, where I took the APD role about 2 years ago and been really happy here. What was the next question? I forgot. So, what do I like about how emergency medicine? So I was one of those people that in med school, I loved everything, right? So I went to my surgery rotations and was super happy there. I went to medicine and I enjoyed talking to the patients for a while. I even went to psychiatry and really enjoyed the people who had a lot of issues there. And I found that emergency medicine was kind of the place that put everything together. Additionally, it was also the place where undifferentiated people come into the emergency department, and it's our job to figure out what's going on, right? Internal medicine might think they're diagnosticians, but we do 95% of the groundwork, and it's exciting to kind of get the ball rolling. As far as mentors in the field, like I said, Dr. Lynn Holden here, she was an attending at Montefiore when I started there. She kind of held my hand while I got my feet wet as an attending. And then she's been really helping me set up a diversity and inclusion program at Morningside West. Dr. Pillow was obviously a mentor in trying to figure out what I want to do with my life and where I want to go to residency. And then sort of along the way, you know, there's people who you meet either at national conferences or SNMA like this, that you figure have something that you enjoy or it's something you admire. And it's just about approaching those people and asking to work with them. And let's say 95% of people are going to be excited to get somebody they get to mentor, right? Because it's nice to be, you know, approached about your interests. And then my last question, what do I like the most about emergency medicine? And that one's pretty easy, right? So I think a lot of us who go into the field enjoy taking care of everybody, right? I don't care whether anybody has insurance, whether they have an ability to pay, where they're from, what language they speak. And I think we are the only specialty that really believes in that tenet of medicine, right? Where we care for everyone no matter what. And I appreciate that all of my colleagues are, you know, people who do good work every day.
Thank you so much, Dr. Serrano.
I guess I'll go next. Hello, everyone. It's great to be here and also to see the common threads that you will see and hear about from everyone. My name is Dr. Lynn Holden. I'm a professor of emergency medicine at the Albert Einstein College of Medicine. I will tell you that I am the 5th African-American female professor of emergency medicine in the country. And I'm saying that to say that's really sad, actually. We really need to step it up a couple notches, especially in academia. All 4 other professors were actually my mentors. So emergency medicine is a very small, a small specialty, or should I say a close specialty, even though we're growing. My story is that I graduated from Howard University undergrad, so HU. All right. Got it right now, Jamili. Got it on time. After that, I moved to back home to Philadelphia. I'm a Philly girl and attended Temple University School of Medicine. Now I know it's the Lewis Katz School of Medicine at Temple, but I attended there. And it was there that I became introduced to SNMA. And it became near and dear to my heart as I was the chapter president there at Temple for 2 years. And really got to know the organization at Temple and build it, and to build the number of minority students, few as there were at that time. And we really became cohesive, and it was really through SNMA. I did my residency in emergency medicine at Jacobi, and I was introduced to it through a program for minority students. So just a heads up that the product of about 7 pipeline or pathway programs through starting in 11th grade. I actually met my husband at a pipeline program for minority students interested in science and engineering at Carnegie Mellon University back in 1982. And you know, that was back in the day, and ET was our first date. So we're dating ourselves. But the power of pipeline programs is that you gradually get to build your network and your experience. And so there are many of those introductory programs to emergency medicine that are popping up all over the country. So I encourage you to take advantage of those. After I did the pipeline program at Jacobi, I absolutely fell in love with it, and with emergency medicine and with Jacobi. And I actually applied to 3 residency programs. So, you know, that was a long time ago. The first residency program had like 1 patient for about 10 providers. So I knew that wasn't for me. The second one, when I interviewed, the person that was interviewing referred to African-American patients as the colored ones. So, you know, that wasn't for me either. And so Jacobi, I just loved the volume and the excitement, and you know, it was just meant to be. So I stayed there. I did my residency there. I was a chief resident my last year, And then I moved on to Kings County, the first year of their residency program. I then got asked to come back up to the Bronx and practice at Montefiore. The residency program was expanding, and they wanted board-certified docs to take over their emergency department. So I was one of those board-certified physicians that did that, and it was a very exciting time. And we built the residency program. I eventually became the site director of the residency program there, and also associate residency director for the entire program. And it was exciting, and it is exciting. We built the program and really had a lot of interesting initiatives that we have started. One of them is social emergency medicine. I know that's kind of sweeping the country now, but we've been doing that for a while, where we want to teach our residents not only about emergency medicine in their box, but we want to teach them about special populations, intersectionality, and how we as emergency physicians can intersect. And when it comes to why emergency medicine, first of all, it's the only place I know of that, you go in, you don't know who you're going to be working with. You don't know what pathology your patients are going to have. It's a constant, you're constantly acting like a detective. When I was growing up, I loved Quincy, MD. I loved Columbo. I love those detective shows. And the emergency department is just that. Also, I like talking to people and listening to people. And certainly in a place like Jacoby and Montefiore, that's what you're doing. You're talking to people and you're really listening to them. And then you introduce yourself and you get immersed in their world. So it's really a privilege to practice emergency medicine. Also, especially now with COVID, there are so many exciting, often tragic, but for us, puzzles. Patients that come in who sat on many different diseases, and now they're coming in with late stages, early stages. So it's really been an interesting time. I'm sure we'll talk about that a little later. And as far as mentors are concerned, yes, I've had many mentors. And I guess point number 2 is not all the mentors have looked like me. Many of them have not, actually. And they have been allies. They have helped me to move forward in my career. And I just want to encourage you that not all your mentors, hopefully eventually your sponsors, may look like you. So just be open. Be open to folks who do not look like you, who will be helpful, very helpful to you. And also folks who look like you, who are very helpful to you. And I'm going to close just by saying that I'm now the chair of emergency medicine for the National Medical Association, which is the parent organization of the SNMA, the Student National Medical Association. And we have programs all year round because one of my pillars as being the chair is to increase mentorship. So you will see that on this call, this other speakers, I have had some influence in their career. Hopefully it's been a good influence, a positive influence. But I am very much into mentoring. Some of you may know of Mentoring in Medicine, an organization which I started with some friends and is flourishing. So I just want to encourage you, just keep your eyes open, keep your ears open, take advantage of opportunities because there's so many out there, especially now during COVID. And just be happy. Emergency medicine is a great specialty. Thanks.
Thank you so much, Dr. Holden. That was really helpful and informative. Thank you.
So I guess I can go next. Hey, everyone. My name is Steve Pamfield. I'm a PGY4 emergency medicine resident at Jacoby Montefiore. So a little bit background on me. I started out, I did my undergrad bachelor's at Lehman College. Then I went to med school at SUNY Upstate in Syracuse. And then I came back here to do residency. And then as far as the other questions, yeah, so I definitely had some mentors who really pushed and advocated for me in emergency medicine. But I'd like to add one thing. I did have some mentors who really pushed and helped me out from other specialties, specifically internal medicine, somebody that's kind of on my mind. So, don't be afraid to seek out people who may be out of the specialty that you're interested in as far as emergency medicine. So how did I get into emergency medicine? I was an EMT for a couple of years. love being in the ER, love bringing patients to the ED. So for me, I was like, oh, okay, this is what I wanted to do. Maybe wavered a couple of times during like second or third year, but I stuck with it, and here I am. So, and what do I like about it? I think similar to what others have said, I like the wide variety of patients, of presentations. You know, you really don't know, you know, what you're walking into, coming into a shift. You know, there's always different types of pathology, and I find that challenging, and I really enjoy that. Thank you.
Thank you, Dr. Panfield.
Guess I'll go also. My name is Mohammed Muratala. I am a PGY3 emergency medicine physician over at Jacoby Montefiore Medical Center with Steve, also with Dr. Holden. My journey, my story, my pathway started in Brooklyn, New York. I was born and raised. I went to undergrad in the City College of New York under the Sophie Davis program, which was a combined BSMD program, now named the CUNY School of Medicine, which is its own program that allows people from high school that are interested in medicine to go directly into the medical field, which is a very nice pipeline program. I chose emergency medicine after going through my third year and a little bit of my fourth year, contemplating exactly what it is I wanted to do. I liked all the specialties. I didn't really hate any one particular specialty, but it wasn't until I actually rotated through the emergency department, both at my home institution. I finished off my medical school over at Downstate. I was in Downstate, and I also did a few away rotations, and that's really what solidified emergency medicine for me. Of course, I had mentors both in emergency medicine as well as out of emergency medicine. I had a lot of mentors while in Downstate in Kings County. Also had a lot of mentors currently here in residency, Dr. Holden being a huge impact for me. But I also had a lot of mentors, not just in emergency medicine, in pediatrics and internal medicine, that really helped me to make the decision of emergency medicine. Thinking about lifestyle, thinking about the type of patients I'm seeing and what it is I want to do, not just in residency, but 10 years, 20 years down the line when I'm practicing as an emergency medicine doctor. Lastly, my favorite thing within the field of emergency medicine has to be the patients. It's my favorite thing of all time. You never know, like you get an undifferentiated patient. There's the medical aspect of it, which is always amazing, but just the social aspect is very, very important. Seeing patients from all walks of life. The patients that you see in the emergency department that you practice really define the community, and that's really what I love about it. Walking into any ER really gets me to get a sense and a feel of what the surrounding environment is like.
Thank you as well, Dr. Muratala. And finally, Dr. Pillow.
All right. So, yeah, short and sweet. God made me. He said, be an ER doctor. So I did. It's been my calling. I love it. Mentors, absolutely. Y'all will probably hear us talk about mentors are key critical to moving through the process. So actually trained at Baylor College of Medicine for medical school and came back here to help start a residency program in EM. So I've been here since the program started. I'm currently not program director, currently the vice chair of education and a bunch of other things in the medical school, but very active. I know Dr. Holden has brought a team here today, but we don't do too bad ourselves. Baylor College of Medicine, very proud to be one of the most diverse programs in the country as well. So make sure to check us out. And then favorite thing about EM, it's just, for me to be doing my calling every day is just incredibly fulfilling. So I think that's where I'll leave that. So excited to be here, and we can jump in.
All right. Thank you to all of the panelists for being here, for sharing your stories, and for providing your insight as well. So we're going to jump straight into some questions. Again, I want to emphasize anybody who's watching, please go ahead and throw some questions in the chat. As you can see on the screen, you can ask your questions in the comment section, and we'll hopefully get to as many questions as we can today. But to start off, I'd like to ask a quick question to the residents who are on the panel. Because you guys are a little bit closer to us as medical students and pre-medical students, we're wondering, how was the transition from medical student to being an emergency medicine resident, and what are some things that you learned about yourself over the course of your intern year?
I guess I can start. Yeah, the transition was tough. It's you kind of go from one day kind of in the background, and the next day you're kind of like at the forefront, really like making decisions with your attending. So I think that part was a little tough. Procedures, kind of getting the hang of things, that's a little tough, but you get used to it. I think the biggest thing is perseverance. You have a tough shift, you have a tough day, but you come back the next day and you keep pushing. You go home, what you struggle with that day, you go home, read about it, learn about it, and ask people about it. Ask your attendings, like, hey, what could I have done better with this procedure? What could I have done better with this patient? And then come back the next day and keep pushing.
Yeah, for me, I would say that the biggest transition from being an MS4, being an MS3, and then going in and starting as an intern was just the degree of responsibility. And I loved it and hated it at the same time. As a med student, it was nice to always be helpful and to try to take ownership of your patients and do the most that you can. But as a resident, I can see how useful I am. I can see how without my presence, certain things wouldn't get done. So I really did appreciate the fact that now I'm in a working position. I'm a valued member. Not that med students aren't valued members, definitely are. But the responsibility that comes with the job, just to take it and own it, it was really something special.
Thank you guys so much. Thank you. And then a question for our attendings on the call, Dr. Pillow, Dr. Serrano, Dr. Holden. What are you looking for when evaluating for a strong applicant for emergency medicine?
I'll start off. I've been part of the residency, as I mentioned before, as associate residency director, site director, but really for 25 years, as part of the admissions quote unquote team for the residency program. And I always get asked this question. And, I would say there are three aspects that I am looking for. The first one is a person who listens to the patient, listens to, those who are supervising he or she and giving them feedback. Secondly, a willing worker. So someone who is flexible, someone who is not going to, who's going to take instructions and go above and beyond, especially when it comes to the patients. And lastly, someone who's respectful. You'll meet many different patients in many different social situations, in pain. And, I just asked and look for residents who will be respectful of the patients and honor them wherever they are in life, and know that there, but for the grace of God go I.
Dr. Holden, that was very nicely said. I think that all applies really for when you do your rotation, right? So we're all looking for you to really kick butt on your home EM rotation and your away rotations, whichever you do. And what Dr. Holden all stands very true, right? Those are really the keys to success in your rotation. Oftentimes it's not how much you know or whether you know the doses of the medication, but it's really how you're perceived by the people who are there, right? So be nice to everyone, no matter who it is, right? Whether it's the person cleaning the bathroom or whether it's the chair of the department, treat them exactly the same because everyone's watching, right? And if you're the medical student that goes out of their way to help somebody, then that's going to be seen. But if you're the medical student that ignores the person who is quote unquote lower than you, that's also going to be seen. So always be nice to the program coordinator, be nice to everyone, and really just be humble and willing to help out.
Yeah, not much to add. So I guess as the prior program director on here, there was one year where a SLO, so the standardized letter of evaluation about a student applicant, mentioned how the woman at the front desk of the hotel they had been using for 20 years to put up students as they came to interview sent the program a letter about how amazing this applicant was, right? So the person at the hotel glowed about this and said, "Hey, I've been taking care of your applicants for 20 years, and this is the most polite, best person you have brought to see this. You have brought to see this program in 20 years. Please take him in," right? And they wrote that in a SLO, and so that person was done at that point, right? So I really want to emphasize. Your interview starts when you get on the plane because you have no idea who's on the plane next to you, behind you, in front of you, etc. And it ends when you get back to your house, right? And so it really is. We're looking for good people, right? Everybody has their specific things they look for at in the actual rotation or performance, but we're just looking for really good people who want to serve. And so if you can show that, understand we're looking for that, you're going to do well.
Thank you all for your insight. Thank you so much. I think we have a couple of questions. Okay, from Mona. Something challenging that I've observed in the emergency department is sometimes discharging patients without finding the cause of their symptoms, and in that case, diagnosing the patient with their symptoms. How do you deal with those situations? I think this can be open to anybody.
I can chime in a little bit. So it's funny, that question kind of like picked a little thing in my brain. One of our attendings at Jacoby, he likes to say, so what are you going to tell the patient when they ask you, "What's wrong with me, doctor?" So it's always kind of like that conversation that we have. That is not part of my practice. I have seen it. I try to make sure I have a conversation about the patient. In the emergency department, it's we make sure the life-threatening things are not going on. And then what's happening after that, it's something you can have your doctor follow up, your primary doctor follow up with you, but it's something you have a conversation with the patient and discuss about what you think is going on with them. You tell them what you think it's not, or what it may be, why you don't think they need to stay in the hospital, or why they need to stay in the hospital, and then take it from there.
I know Dr. Serrano wanted to say something, so I will.
Go for it, Dr. Holden.
So that's one of the challenges of practicing emergency medicine, that sometimes you just don't know. There's this saying, worst first, and how can I not kill this patient, honestly? And that's basically what we're there for. And so there are times when patients will say, I thought I was having a heart attack, or I thought I was having a stroke. And, a lot of what we do is reassuring the patients. We listen to what they have to say. And then we give them evidence as to why or why not, in our best judgment, that they are not having a heart attack or stroke, with various tests that we do. But there's always the caveat of, they could walk out the door and collapse. Like, we don't know, we just don't know. So we do the best that we can, the best that we know how, with the resources that we have. But there's always the fact that, this may be early in the stages of, something. So we don't know. We're seeing you at point A, and at point C, you could get really sick. So we're open 24/7, and we assure the patient that, please come back if anything is different. Number one. And number two, we make sure that the patient has follow-up. If they don't have a doctor, then we make sure to get them a doctor or some resource so that they can be followed up.
That's such a great question, because it's something that I've struggled with for a long time. But my strategy now is I walk into the room with a really excited expression, and I tell them, I have some fantastic news. All your tests are perfectly normal, which means that you are doing great. And so I turn their negative workup into a positive experience, telling them, wow, you don't have a heart attack. Isn't that fantastic news? We're going to be able to get you home, and you're going to get better on your own. This is amazing. right? And oftentimes the patient will respond with, oh, this is such a relief. So it's all about kind of turning the situation in order to make it sound positive.
It's been something that's also been frustrating for me. Just as a PGY3, I've seen so many patients, especially early, maybe like in my intern year. Oh, like what's going on? And it's like saying I don't know is always so difficult, especially when the patient's coming to the hospital because, you know, they feel sick, they're in pain, they want to know what's going on. But I really just set expectations. I communicate with the patient. I give them insight to what it is to be in the profession, and because they've given me insight into their own lives. So I just try to have that conversation with them and let them know that I'm happy that you came to the hospital because you care enough about yourself because you were feeling sick and you were worried. But on our workup, it was things were negative. So the biggest things that we were worried about that could potentially kill you, you're not experiencing any of those in this current state, which is good. And I just try to reassure them that that's something that's good, and always encourage them to come back if they feel worse, if the symptoms aren't resolving, and to always follow with the primary doctor. And if they don't have one, make sure I always refer them and try to make sure that they get good follow-up. I think that conversation is extremely, extremely important.
I will say just quickly that one thing that, kind of frustrates me is patients who come in and, they have something that can be fixed and they insist upon leaving. And, it's, I have to feed the cat, I have to do this, I have whatever appointment, so that situation can also be challenging where that a patient is having a heart attack, or the patient's electrolytes are really, really low and we can replete them, or they have a bad infection and they need IV antibiotics, but they insist upon leaving. So, that's sort of the reverse where you try to get them to stay. And, if they don't want to stay, and, again, that's where the respect comes for the patient. If they don't want to stay, but they understand the consequences of leaving, and they understand that you certainly want them to stay because with X, Y, and Z medication, they would feel much better. You have to accept that and document it, and document that the patient understood, have them sign something, and still let them know we're open 24/7. So after you take care of your business, please come back. So that's another side of emergency medicine that can be a bit frustrating.
Thank you guys so much. And I actually had a question I'd like to throw in there. Myself as a rising MS4, and I think there's a good amount of MS4s watching this as well. Obviously, going into emergency medicine, slows are incredibly important, right? So I know ACEP has recommended that we all do 2-away rotations so that we can all get our slows and everything like that. And my question is, more so on the attending side, but I'd also be curious to hear about the resident's point of view as well. What do you guys look for, I guess, on a day-to-day level that just makes kind of like a stellar medical student, stellar acting intern that you'd really be inclined to have in your program and give a really great slow? Like, what are some of the things that they're able to do kind of on a day-to-day basis while on a away rotation with you?
I'll go first on this one. So I'm very when I answer, I kind of answer it not riddles, but like process driven and thinking like big picture. So I'll say it like this: when you go to a nice restaurant, can you tell the difference between a waiter or waitress that don't really care about what they're doing and don't really care about your food, and you're a little worried about your food, versus someone who is like on top of it? Like before your knife hits the floor on accident, they diving for it, grabbing it, and saving that knife from hitting the floor, those sort of things. So there's a lot of intangibles in there, and it shows dedication and passion shows. It's active, is what I would say. A lot of students wait to be told to do something versus knowing how to be active, volunteer the information about their patients, volunteer to help without being, too much, which is great. And I think overall, though, one of the tactics that I tell students to use, which is, it's a Jedi mind trick because there's actually some neurobiology behind it. I like to talk about it. sometimes, is that you actually start the shift. You say, hey, Dr. Holden, I would love to do a great job for you today. What are you looking for from an excellent student? And then she will tell you the 4 or 5 things. And then guess what you go do? Those 4 or 5 things, right? Because at the end of the day, there are some people with quirks. Like, we're quirky in emergency medicine. I hope, I ain't trying to lie to y'all. Just let's get it out there. We're a little quirky, right? So although we're all looking for the same sort of things, Dr. Serrano might be looking for X, whereas Dr. Panfield might be looking for Y more so. So you just ask at the beginning of the shift. But if you can start to think about, what makes a good waiter versus a great waiter, right? What makes a good, you take something, look, we just, real talk, took some stuff back to Target, right? Because my kids like the toys, but he didn't want this particular toy. And initially dealt with somebody who clearly did not like her job, and then dealt with somebody who was just wonderful. Same place, same job. There's that tangible difference. So if you love what you do and you just actively express it, that it'll be there. And then just ask, what are the 3, 4, or 5 things you love for me to do to show that I am passionate about emergency medicine? You can't go wrong.
Thank you, Dr. Pillow.
Yeah, that was a beautiful analogy, Dr. Pillow. I don't know if I can top that. But it's very true, right? So for those of us who are going to work with you on shift, right, the attendings, they want you to remind the attendings how exciting this job is, right? So part of the benefit, part of the joy of working with medical students is seeing how you get excited about, wow, this is the first time I've seen pancreatitis. This is so cool. The lipase is high and I've never seen this before. We're like, oh yeah, it is exciting that we're getting pancreatitis. Wow, this is really interesting in how we treat it. And so your passion, your excitement, or even if it's something that's not exciting, but if you're showing that passion and interest in being there, it's going to make our day brighter, right? So your job is to kind of almost make that attending's day a little bit better by you being there. And that's going to get you a really, really good email.
Okay, so it looks like we have another question here. So from Akira, to everyone, what action did you take during your medical school career that best prepared you to be strong emergency medicine applicants?
I can answer that. Well, to start, what I did throughout my medical student career, was really, in my rotations, in every single rotation I had, I really looked at it with an open mind. I stepped into every single rotation, basically saying that this may be the only time, I don't know what specialty I'm going to do, but this may be the only time I'm going to see this particular specialty, and I want to gain as much as I can out of it. And looking at it from that perspective allowed me to just do my best every single day. It didn't matter if I cared about the specialty. It didn't matter if I wanted to go into it or not. It didn't matter if I was ever going to see something ever again. I just wanted to do my best and be my best. And in doing so, it really allowed me to get as much as I could out of each rotation. And when it finally came time to making that decision of, oh, hey, like, what do I want to do for the rest of my life? It was a lot easier after, getting the ins and outs, seeing the nitty gritty. And when it came time to choosing emergency medicine, it was a pretty seamless process after experiencing it and comparing it to everything else I experienced.
So I can chime in as well. So one of the things I did during my 4th year is I did a lot of, I knew I was going into emergency medicine, so I did some ancillary kind of a rotation. So I did an ultrasound rotation, which I thought was very helpful. I also did a rotation where I just kind of hung out with the radiologist, kind of read x-rays, just basic like chest x-rays. I thought that was very helpful because I emphasized those things in my application. So I think it kind of like helped me kind of set myself apart from other applicants.
All right. Thank you guys so much. So the next question is from Saren. I hope I'm pronouncing your name correctly. Thank you all for this wonderful session. I'm a 4th year DO student at Ohio University, HCOM. College of Medicine. I was wondering what your thoughts were about USMLE/COMLEX and how DO students can navigate the application process without taking the USMLE or taking just step 1 versus step 2.
All right. So as a prior program director, I got the DO, I got the IMG questions ready to go. So I hope you all ready for blunt, open, honest, because if not, I probably shouldn't have invited me. So there's a stigma. There's a stigma about DO applicants compared to MDs, period, point blank. I respectfully, anybody that says there isn't is either enlightened that they truly don't have one, or they're closing their eyes really, really tight and just hoping that nobody sees through them, right? So you gotta take it head on. So I've been in conversations where the COMLEX versus the STEP was compared to apples versus oranges. How do you compare the two? How do you kind of put those two together and look at them? And there are formulas and there are ways to think about it. But I think at the end of the day, you look at the lay of the land, you think about where you fit and how to make yourself competitive. I think you have to look at it as most programs are going to be expecting a step score. And I believe if this is primarily fourth year students, you all are in that window where step 1's still available, yes? So I would take step 1 as a prior program director and someone still very involved in choosing residents for our program, and who now consults with other programs about diversity, equity, inclusion, and doing better recruitment that's not just based on scores. I will tell you, I would highly consider still taking step 1 right now, because we as a nation, programs across the country, not even just EM, don't know how to do holistic review yet in a really, really thought out way. We're working on it, right? There are definitely programs, like clearly Montefiore is doing great, right? They have leadership with Dr. Holden. There are programs that have figured it out and figured out how to do these things. Many haven't. And so they will be looking at these things. And so obviously it's a case-by-case sort of answer, but you're going to do best by making yourself competitive as much as possible along the quote-unquote classic lines. Not to say scores are everything, but it's the last year that step 1 is going to be an option. People are going to be looking at step 1, right? And so I think you got to take that stigma and those inequities head on. Inequalities actually is a better word, head on, as it were. But it really does take a case-by-case sort of analysis. So don't just jump in. Talk to your mentors, get a sense of where you're at, your likelihood of doing well, et cetera, and figure out what to do from there.
Yeah, I agree. I think that there are 3 strategies that I give to students who are in osteopathic schools. First of all, to definitely take step 1. I mean, oftentimes, if it is a MD program, an allopathic program, you're comparing apples to oranges as opposed to apples. So if you take step 1, we certainly can compare apples to apples. If it's a DO program, then, and there are DO emergency medicine residency programs across the country, then it's a different story. They're used to, they probably don't see step 1. They probably see more complex. So that's their comparison of apples to apples. So that's number 1. Number 2, see where students before who have graduated, who have matched in emergency medicine, where did they go? And what sort of track record does your school have at that or those institutions? So that would be where I would concentrate my efforts. To number 3, I know it's hard to do a rotation. I know things are starting to open up now, even though we're still in a pandemic, but try to make sure that you are a known entity, whether you rotate there and do extremely well, or if they have lectures that you can attend, Wednesday lectures, or if they have webinars, even talking with the program director and the APDs, make sure that they know that you're interested in their program. So I think if you follow those strategies, it will be a much less stressful process to applying to residency programs.
All right, thank you guys again. Next question is from Megan Short. Question is, how as an ED physician can you build a relationship with the community, both so they feel comfortable seeking your help, but also willing to take the education and implement in their daily lives? It's a loaded question, she says.
I think I can start to answer it. I don't have a perfect answer, but from my experience, the way you can start to build a relationship is starts with just listening to the patient. From my own experience in working, I have a patient that comes in telling me that they have high blood pressure, but they don't take their medications. I ask them why. Throughout my time period, I, as a physician, we're not just there to, take care of them in the moment as an emergency medicine doctor and then send them along their way. There is a little bit of time, or sometimes a lot of the time, where we can really figure out exactly what's going on with this patient, learn more about the socioeconomic factors that affect their day-to-day lives. We ask them a lot of directed questions, but there are times where you can just sit there and have them speak to you. You can get a sense or a feel or vibe of exactly where they come from, what challenges they may or may not face. And in knowing that, you can try to adjust how the hospital you work for does something. If you notice that there are so many times where patients don't have access to something, you can ask administration, hey, is there a program or initiative or something that allows patients to get access to this? And a lot of times the answer is yes. So once I get that information, now I can provide that to my patient. And that's something nuanced that I can give to my patient. And I also learn about the community that I'm in as well.
I think I'd like to say something to that respect, but more in terms of fixing the system, right? So I think one of the reasons that patients don't trust the system is because their providers don't look like them, right? And so one of the things that SNMA is doing, and I think a lot of us on this panel are trying to do, is change that. And so the way to get people to trust the people that are taking care of them is when they look like them. And so if your community looks like your physicians, then that's important. And so if we get more of you guys to come into emergency medicine, to become physicians, to become leaders, that's how we're going to get the community to really trust when they come in and talk to us.
Yeah, I definitely want to echo that. And I think that, the hospital and getting involved. So, for example, I mentioned that we started a social emergency medicine program within the residency, and that's where the residents are going out into the community. And they're, feeding the, hungry, and they're, at health fairs and, all over, really trying to build those bridges with the community. Through mentoring in medicine, since 2006, I've had students that look just like you in the emergency department. And the reason for that is twofold, so that you can learn the language of emergency medicine and medicine in general, but also so patients can see you and you can learn about patients, patient care, patient comfort, and carry that through with you to throughout your experience, whatever you decide to go into. The great thing is the emergency department is sort of the meeting of the minds. You see almost everything in the emergency department, and you take that with you. I just want to comment on something that Dr. Pamfield said earlier, which is reading. Very important. So, if you see something in the emergency department, whether you're a medical student, a resident, a pre-med student, go home and read about it. That's how it will stick. So you'll see some fantastic pathology, but it won't stick unless you really read about it. And you have to be a self-starter in emergency medicine. We are type A. So we do a lot of reading, and this COVID pandemic has certainly exemplified that. So, start today. Just be curious, be hungry, and read.
Okay, thank you all again. Next question is from Tiffy. What are your thoughts on the future of EM? So I know that she's talking about some of the ACEP's predictions about the oversaturation of EM providers. Says, if these trends persist, do you think that those who are interested in EM now should shift their interest to other specialties with a better job outlook?
do what you love first. Do what you love, period. And it'll make way for you. So I will point out that ACEP's prior predictions were a shortage, and that life happens, COVID happens. I know we all know that. It shifts, it moves. It's unpredictable. So at the end of the day, my answer is going to be do what you love. And make yourself, that when I see things like that, I say to myself, oh, I see that prediction, but whether or not that comes true, I myself, I'm going to be so competitive, so good at what I do, so hungry to take care of people and be in this ED and to train residents. They won't have a choice but to give me more jobs, to give me more opportunities, etc. Right? And so I was at a interesting talk recently that talked about AI in medicine, and the speaker's point wasn't that AI is going to take over and replace doctors. He said AI doctors that learn to use AI are going to replace the doctors that don't know how to use AI, right? And so the predictions of things that may happen, and I could be completely right or completely wrong. It doesn't even really matter. What matters is, I think, when you are doing what you are meant to do, what drives you, what you wake up and you love to, even when you're tired. There was a question in the comments about some of the good or bad of EM. Overnight 12-hour shifts are the devil. They are the devil. Like, that's just the first 4 hours. It's like, oh yeah, go intubate this one, start a drip on that one, do a CPR. And then later you're like, wow, I don't even remember my name. Am I signing stuff right? What's going on? But that's okay. That's part of it. And so when you're still like that and still love what you do and want to do more, you've found where you should be, and it will make a way for you. It will make a way for you, right? And so whether predictions left, right, up, down, do what you love, follow your passion, and the most of the other things will be a detail. I don't know where it's headed, but it will be a detail.
I can also say that through the years that I have been practicing medicine, there have been too many OBGYN doctors. There have been too many anesthesiologists. There have been too many of this and too many of that. So it's like, it comes and it goes, but it evens out in the end. So I echo loudly what Dr. Pillow said about, what brings you joy, and doing the best that you can do within that aspect of life.
Thank you all. Hopefully we have time for one or two more questions. Next question is from Amber. I think a lot of us went into medicine thinking about the physician-patient relationship at some level, which tends to be easier when you see the same patient multiple times in their life. I'm personally interested in EM, and I'm wondering how you all think about or build a relationship with the patient in such a short interaction. Thank you all for your insight so far.
I will start off. First of all, thank you for that question. It is one of those, stopgaps for a lot of people. They love to see patients over and over again, or in EM, they really don't want to see patients over and over again. But I will say, one of the challenges, and I think it's a great challenge, is that you have to get to know a patient very quickly, and that patient has to trust you very quickly. And you have to have a very high level of social and emotional intelligence, which develops over time in order to do that. There's a great book called How to Win Friends and Influence People by Dale Carnegie. And I think that that book really will give you a lot of insight into how people want to be treated, so that the job is made easier when you do see a stranger who's often under duress and often doesn't want to talk. But you have to be able to calm them down, to be empathetic, compassionate, and also get the information that you need from them to make an intelligent decision. The other aspect of emergency medicine is there are some people that you see over and over and over again. So don't be fooled. You will have your posse that comes in, and they will know you over the course of time. And when you don't see them, you get concerned. when you see them and they're not acting like they did the past 15 times you saw them in the past, 3 months, you get concerned. So there is that aspect. You do see some people over and over again.
I'm glad this question was on here because I think it's one of the things that is beautiful about emergency medicine is, and I remind myself every day of this, and I tell all my residents about this, but remember that every patient you see in the emergency department, this is probably the worst day of their year, right? Nobody wants to go to the emergency room. Nobody wants to be sick. And so these are patients that are going to remember you for the rest of their lives. And I can tell you this happened to me when I was in residency, and Nashville was a much smaller town. But it happened several times where I went to the grocery store and a patient would stop me and say, oh my gosh, you were the doctor for my mother in the emergency room and you admitted her to the hospital. And I had no idea who this person was, but they all remember us. And so keep that in mind and remember the privilege of taking care of people who are struggling. And it may not be the most meaningful interaction for you, but it may be the most meaningful interaction that person has had in a long time.
Yeah, just wanted to add on to what both Dr. Holden and Dr. Serrano said. I think, we think of that EM, the interaction between patients and doctors in the emergency room as kind of short and doesn't last very long, but it actually does make a big impression on patients. In that short amount of time, you can have a lot of influence. You can have a lot of meaning into the patient's life. So I think, although it is a very short interaction, it is definitely a time where you can build a lot of trust and make a big difference in that patient's life.
Okay, I'm getting a little clues here. So I just want to give you all some resources because I know we're close to the end here. So first of all, thank you for listening to us. Thank you for allowing us to talk about, our experience in emergency medicine, sharing that with us. We certainly are all very vested in you and your future. So please contact us if you have any other questions. Just 3 resources for you. First of all, the book, How to Win Friends and Influence People by Dale Carnegie. Very important. I think it's mandatory reading for all of you. To be successful in emergency medicine, along with other lessons on how to increase your social and emotional intelligence. Number 2, there is a seminar series, 8 webinar series put out by the Society of Academic Emergency Medicine, the Academy of Diversity and Inclusion in Emergency Medicine. The link will be put up for you to check that webinar series out. It goes from everything why emergency medicine to how to find a mentor, to how to get a great letter, to how to interview. And this was put on during the pandemic for you all, especially those of you who do not have emergency medicine at your institutions. And it was basically 40 distinguished faculty from across the country, leaders in emergency medicine, who came together to create this for you. It is archived again on the SAM or ADIEM website. So hopefully you'll get that link and you'll be able to partake of that. And finally, the emergency medicine section of the National Medical Association is planning a very robust reception and program. We'd love to have you join us. If you go to nmanet.org, you'll be able to, or just Google the National Medical Association virtual Scientific Assembly and Conference. That's coming out July 16th, 17th, 18th, 19th, and 20th. It's free. So I encourage you to come and learn about ECMO and learn about all the terms that we're using and how we've gotten through COVID, troponin, and all these terms that you're going to have to find out anyway. But it's great to be able to be introduced to it, by your NMA family. So that's another aspect. And I'm going to step back now, but I just want to thank you again for your participation.
And on that note, I would like to thank all of our amazing panelists. Thank you all so much for joining us tonight and providing your wisdom and insight. I think I speak for everybody who's watching when I say I'd like to give you guys a virtual round of applause, but obviously everyone else can't be seen. Thank you, Dr. Holden. Thank you, Dr. Phillip. We appreciate your support of SNMA and our membership. For those of you in the audience, please follow us on Instagram at SNMA_official and at SNMA on Twitter. And please like us on Facebook as well. Most importantly, if you're not a national member, please visit snma.org to sign up and get connected. So thank you everyone for tuning in, and look forward to the pediatrics panel, which is going to be next Wednesday, the 14th at 8 p.m. as well. Thank you all for joining.